All right. Good evening, everyone. Thank you so much for making time. Um, we'll have a presentation on ITP today, and the reason for choosing this as a topic is the treatment of ITP has actually changed. It has changed dramatically in the last 1.5 year. The second reason for having this talk is that we are going to face a dengue season in the next few months. And quite often what happens is either we misdiagnose and mislabel ITP as dengue or dengue as ITP. Both are happening. Today, I thought I'll deal with the first one, and then around May, we will have a small session on how to manage low platelets in dengue fever. Going forward, I'm kind of going to start off with a concept that you might have heard me give in other talks as well. Whenever we are looking at any cell being below normal, any blood cell, so it's RBC, that's hemoglobin, or WBC, or platelet. The way I approach it is slightly different, and it's more of a conceptual approach. So before going to low platelets, I will use low hemoglobin as a example as to how I approach a cytopenia. We need to understand that in our bones, we have bone marrow. And bone marrow is the factory which makes these three cells. It makes red cells, white cells, and platelets, right? Any factory, for it to work, it needs raw material. Now, what are the raw materials that are required for the bone marrow to work? What is required to make hemoglobin? So we need iron, vitamin B12, and folate, correct? So whenever we have a patient coming with anemia, you would typically think that maybe there is a production problem. Maybe it's nutritional anemia, because that's the commonest diagnosis. And most of the time you will be correct, right? You will give iron tablets. You may even give multivitamin B. And we are a developing country. This is going to be the right diagnosis and right treatment for majority. However, in spite of giving iron, if somebody's hemoglobin does not improve, or there is a relapse of anemia, it improves for some time and comes down, then you start thinking, what is happening, right? Is there a congenital defect? That even if I give raw material, the marrow is not able to produce? Is there a thalassemia trait, thalassemia minor, or something else is happening? Now, for that something else, you will typically refer the patient to us. And as hematologist, we then do a bone marrow exam to actually look at the factory. Does the factory have workers, or is it empty? Right? No point in giving raw material if there are no workers, which means there is aplastic anemia. Or is the factory filled with bad workers? So leukemia, lymphoma, myeloma, some kind of malignant cells, sometimes breast cancer metastasis. Bad workers which are occupying the factory, they're not allowing the good workers to do their job. Okay. After bone marrow, if we realize that no, everything is fine, raw materials are good, marrow is healthy, then what's happening? The factory is working. Maybe whatever the factory is making is getting lost or consumed. So there may be blood loss externally, internally, or the blood may be breaking up in the blood vessel. Hemolysis. Okay. So this is how I conceptually look at any cytopenia. Raw material problem, empty marrow, marrow packed with bad cells, Everything working well, but increased consumption. Let us try to apply this same thought process to low platelets. Yeah. B12 deficiency, folate deficiency can lead to thrombocytopenia. Along with anemia, there may be slightly low WBC, there may be low platelets in vitamin B12 deficiency. It's possible. Okay. Congenital syndromes causing low platelets are very, very, very rare. In the last, 20 years that I'm doing hematology, I've only seen 3 patients of congenital A megakaryocytic thrombocytopenia. That means somebody who's born without megakaryocytes in the marrow. And megakaryocytes are the cells which make platelets. They are the precursor. It's very rare. But empty factory is common, aplastic anemia, factory packed with cancer or other bad cells, common. But the commonest cause of low platelets is increased destruction. Healthy factory, good nutrition, increased destruction. And what do we mean by increased destruction? What do you think? So increased destruction could be autoimmune or non-immune. Either the immunity is killing the platelets or something else is killing. What else is killing? Maybe there is TTP. So the strands, fibrin and other strands in DIC are cutting and breaking off the platelets. Maybe there is hypersplenism. So when the blood flows in the spleen traps platelets, but there is some kind of consumption. Or maybe there is dengue fever which will start, where again there is peripheral destruction of platelets. So this is the conceptual understanding of thrombocytopenia. How do we actually put this into practice? How do we actually evaluate a low patient who comes to us with thrombocytopenia? You first always take a history and examination. You will ask, okay, do you have bleeding? Is there bleeding? What kind of bleeding will we see in thrombocytopenia? Yeah, critical organs can be there, and it can also be mucocutaneous bleeding. Mucocutaneous bleeding. Bleeding is broadly of 2 types. If it is on the skin, so tiny petechiae, purpura, ecchymosis, or mucosa, so mouth, gingiva, palate, genitourinary tract, menorrhagia, mucosa. Skin or mucosal bleeding is because of a platelet problem. Either the platelets are low or they are in good number but they are not working. Maybe because of aspirin or other such drugs, they're not working. Hypofunctioning. But deep bleeding, this is superficial. Deep bleeding in muscles and joints is a different problem. Deep bleeding in muscles and joints is usually not caused by platelet. It is caused by hemophilia, coagulation factor problem. So when there is a coagulation factor problem, you're going to get deep muscle and joint bleeding. Platelet problem, superficial, cutaneous and mucosa. All right. So we take this history. We ask, okay, is there any bleeding from your mouth? Show me your tongue. Any bleeding in urine, stools, etc. Along with low platelets, you will check if other cells are okay. So any sign, symptoms of anemia. Do you have breathlessness, lethargy? We will look for sign, symptoms of low WBC. Any infections, right? Fever. Okay. And any other systemic problems, cough, cold, urine motion, weight loss, general questions, right? In examination, you will look at the same things. You look at the skin, the mucosa, liver, spleen, lymph nodes. That's it. Examination, clinical examination in hematology is practically this: pallor, skin, mucosa, liver, spleen, lymph nodes. Right? Why are these important? I'll come to that. You will then repeat a CBC, or you will call your pathology friend and say, "Arey, I got this patient, platelets are low. Can you repeat the CBC?" And we need to understand that current cell counters, automated cell counters are fantastic machines. They're really good. If the lab is doing proper quality control. Okay, very important. Every lab does not do quality control. They are supposed to run a QC every day. They run once in 6 months or 1 year. That's why tests are not reliable. But if the lab is doing proper QC, these are fantastic machines. You can trust them. Okay, except in two conditions. You can trust your automated cell counter report if it is proper quality control is done, except in two conditions, and that is what is called as false low platelets, pseudo thrombocytopenia. What is this pseudothrombocytopenia? Which means actually the patient has enough platelets in the body, but you're getting the wrong report from the machine. Okay, this happens in two conditions. First is what is called as giant platelet syndrome. Giant platelet syndrome. Now, if you look at this peripheral smear, you will see the RBCs. These are the WBCs. And you see these tiny specks, this one and this one and this one, these tiny dots, they are the platelets. But this patient has giant platelet syndrome, which means normal platelet volume is 4 to 11 femtoliter. In this patient, you see, this is also a big platelet. It is a giant platelet. Just like, some of us are tall and some of us are short. Some of us have bigger platelets. Now, our automated cell counter has a software. The software says that the cell counter is counting the number of cells and measuring the size. The software is, if the size is between this much and this much, count it as RBC. If the size is between this much and this much, count it as WBC. And the smallest size, you count it as platelets. That's how the machine will count. So if the platelet is big, it will say this is kachra, dust particle, and it will not count it. And thus, it will give a false low platelet count. So platelets may be more than 1.5 lakh. It will, some machine will show 70,000, some machine will show 40,000, another machine will show 90,000 for the same patient, right? So there are varying counts. How do we get a proper count? Manual platelet count. We call up our pathology friend and say, hey, platelet volume MPV is high, must be giant platelet. You look under the microscope and count and tell me what is the correct. Because the pathologist will count this also as properly as platelet. It will not miss the giant platelets. The second condition which causes false low is, in some of us, when we collect a blood sample in an EDTA tube, normally it is collected in EDTA tube, right? And we send it to the lab. EDTA is supposed to keep the blood in the liquid form. It does not allow the blood to clot. So that it goes in liquid form, the machine can do the test. But in some patients, the EDTA can actually excite and activate the platelets. So the platelets stick to each other. You see, that's a platelet clump. These are all tiny platelets sticking to each other. There must be thousands in this clump. Now, because it's in the clump, the machine can't count. The only way we can know is again with a manual platelet count and telling your lab, hey, this is because of EDTA. Collect sample in your PTA-PTT tube. Okay, in a different tube, use different anticoagulant. Or take a direct prick, slide, smear, count under the microscope. So without any anticoagulant. These are two conditions where manual is better than machine. Otherwise, machine is far more accurate. So whenever we get a patient with thrombocytopenia, we take a history, we do examination, and we assess, is this real low platelet count or pseudo? Once we know it is real, then your pathology friend has to tell you, how does the blood look under the microscope? Are there any broken RBCs? If there are schistocytes, maybe this low platelet is because of TTP, thrombotic, thrombocytopenic, purpura. Different diagnosis, different treatment than ITP. Are there any features of megaloblastic anemia? Is there malaria in the smear? Right? And most importantly, do the WBCs look normal? If our pathologists say atypical cells plus, we have to rule out leukemia, lymphoma. It may be cancer. And that may be reducing the platelet count. So this is how we think. First, by checking the peripheral smear. Then, of course, you will do your dengue, IgG, IgM, and NS1. Right? Right thing to do. You'll do some biochemistry. You'll do creat, because in HUS-TTP, creatinine may be high. That may be the diagnosis. LDH may be high in the same conditions, right? And if you think, all right, I think this is ITP, I'm going to give steroids. No, you have to, before giving steroids, you have to do a bone marrow examination. Any idea why? Steroids are part of leukemia chemotherapy. Steroids can kill lymphoid leukemia cells, lymphoblastic leukemia cells. So without bone marrow, if we assume it is ITP and we give steroids, the steroids will go and temporarily kill off the cancer cells, and you may miss the diagnosis of leukemia. We see this every 3-4 months. We get a patient like this, gets labeled as ITP, steroids, platelets have gone down, they come up because steroids are killing the cancer cells. After some time, cancer cells grow back, platelets go down, right? This continues for a few months. Then they come to us, we do a marrow, there's actually leukemia. You don't want to do that. ITP means your bone marrow is normal and there is immune consumption in the blood and spleen and liver. Your bone marrow is normal. ITP is a diagnosis of exclusion. It's a diagnosis of exclusion, right? To the point where today, what is the full form of ITP? Immune thrombocytopenic purpura. If it's changed to immune. Previously, we didn't know what is the cause, so it was called idiopathic. Now we know it's immune. I had a very tough boss when I was doing medicine. Okay. And I labeled a patient as ITP without doing marrow. And she asked me, what is this ITP? I said, Madam, idiopathic. She said, do you know the meaning of idiopathic? I said, no, madam. Have you done bone marrow? So you're not done testing. And you labeled. Yes. She said, see, the meaning of idiopathic is that the doctor is an idiot and the patient's condition is pathetic. Right? Doctor is an idiot. He said, don't be like that. Do the right test, get the right diagnosis. You'll probably have good success of treatment. So once we have gone through this thought process, I now want to introduce one concept that I called high-risk cytopenia. This will tell you when should you do a marrow, whether there is anemia, thrombocytopenia, low platelet. Okay? First, understand that bone marrow, blood, liver, spleen, lymph nodes, they are all one system. So when there is a problem in the marrow, the lymph nodes and liver spleen might also swell up. If there is leukemia or lymphoma, these may swell up. So if you have a patient with lymphadenopathy, hepatosplenomegaly, along with one of the cytopenias, do a marrow. You might be missing a hematologic malignancy. If more than one cell line is affected, only anemia, fine. Along with anemia, WBCs or platelets are also low. Maybe something is wrong with the factory. test the factory. Have a high threshold for doing this test, bone marrow examination. If your pathologist say there are some atypical cells, I don't know what it is. Look at the factory. Maybe there's leukemia in the marrow. Yeah. Or you are waiting and waiting and the patient is not recovering. You have given B12, you have done this, you have done that. Prolonged cytopenia. Factory. Okay. Recurrent. You have treated. Initially, it improved and then came back. Okay. And before you give steroids for whatever diagnosis, don't no. And I hope we are not giving, hydrocortisone before all blood transfusion and all that. We should stop those practices. It's not good. We end up missing a lot of diagnosis. Routine blood transfusions don't need any pre-medication with steroids. Okay. So these are the patients where we have to have a high index of suspicion. Do a proper test, look at the factory, do bone marrow exam, CT scan, PET CT, whatever. Okay. I call these as high risk cytopenia. Practically, what I do is platelets more than 1 lakh, you can wait and watch. Normal is 1.5 to 4.5. Between 1 and 1.5, you can wait and watch. You can say, okay, I'll repeat tomorrow or day after tomorrow. Once platelets go below 1 lakh, you have to start thinking. You have to see that it is genuine thrombocytopenia. It is not pseudothrombocytopenia. Look for fever, liver, spleen, lymph nodes. Peripheral smear, rule out TTP. Yeah, rule out TTP. Look for atypical cells, right? And none of these are there. You have to do a marrow. Dengue negative, no TTP, high risk cytopenia. Okay. However, if any one of these is there, for example, you've done dengue test and the dengue test shows NS1 positive. Okay, great. Maybe platelets are low because of acute dengue fever. Majority of the patients are going to be uncomplicated. You wait and watch, hydrate them. You do CBC once in 2-3 days. Watch them. In dengue fever, from the time of onset of fever, in 2 weeks, the platelets start recovering. If they don't budge at the end of 2 weeks, maybe it's not just dengue fever. Okay. How many times we see, yeah, dengue is positive, but there may be underlying aplastic anemia or leukemia. And by chance, the patient has been diagnosed now, right? So if platelets start recovering in 2 weeks, leave them alone, nothing more. If they are not, you have to evaluate. Okay. This is how I manage patients who come in the OPD, stable patients, low platelets. What about patients who come, who are admitted in the ward? We get a consultation. Can you see this patient in the ICU or the ward? Was admitted with appendicitis and platelets are low, right? So I will go, most probably Nishit will go and see this patient from our team and he'll say, okay, let me see since when the platelets are low. What was the platelet count at admission? If platelet count was normal at admission, if it was normal at admission and only later on it has dropped, then we'll start thinking why. Doesn't look like a primary marrow problem. On admission, platelets are okay. WBC is okay, right? But something has happened later. There is infection, sepsis, maybe DIC. So we'll do a PT, APTT, D dimer, right? If that's positive, DIC because of sepsis, you can't do anything for platelet. You treat the sepsis, platelets will come up automatically. Simple. This is not a primary marrow problem. All right. If no, there is no DIC, no fever, sepsis, your PT, APTT, FDP is okay. Then you have to start thinking what is happening. Here, one of the things that we do is we also have to rule out what we call as HIT, heparin-induced thrombocytopenia. Heparin-induced thrombocytopenia. When our patients are admitted in the ward, practically everybody has an IV cannula. Nurses flush the IV cannula with heparin. No, you can do it. Majority of the patients, nothing happens. In some patients, that heparin and platelet will bind and they will together make antibodies. And those antibodies will then bind to the platelet and kill it. HIT. Typically starts after 5 to 10 days of admission. Okay, not a marrow problem. So there is a blood test for this HIT assay. Sometimes there can be TTP, so we'll look for schistocytes, creat, etc. Right? And all of these things are negative. Then we have to do a marrow. We don't have to do a marrow immediately. Many times when we are called, the consulting physician will say, hey, why don't you do a marrow? I say, no, yeah, looks like pneumonia, sepsis, going down, as you give antibiotics, as fever settles, infection settles, platelets should come. If it doesn't, we will, right? What if platelets are low from admission? Then maybe there is a primary hematology issue, right? That infection may be because of neutropenia, maybe because of marrow related low immunity rather than the other way around. In such patients, we will do early marrow test, right? And again, before marrow, no steroids. Now let's come to some practical details of for ITP. We know it's an immune problem and it's an acquired problem. It happens later in life. This is not a congenital issue. So if a baby is born with low platelets, it's not ITP, right? So it's an acquired disease, commonly seen in children, also seen in adults, right? For us to even think of that, again, 1 lakh, 100,000 platelet. If it's less than that, we start testing. Why do we test? Because the lower the platelet, the higher is the risk of bleeding. Okay. Why does this happen? Something triggers autoimmunity. Something triggers autoimmunity. The patient's immune system makes antibodies against the platelets. It kills the platelets in the, it binds to the platelets. These platelet bound antibodies go to the spleen and the spleen eats them up. Okay. So the platelets are actually killed in the spleen with the antibodies bound to, and the liver, of course. These antibodies also go into the factory. They go into the marrow and attack the megakaryocyte. Megakaryocyte is a big cell, and the megakaryocyte plasma keeps on breaking off and forming platelets, plasma and cell membrane. So megakaryocytes makes the platelets. So these antibodies will also go to the marrow and prevent production. So not only increased consumption, decreased production. Now, I'm going to introduce you to something called as thrombopoietin. Thrombopoietin. Marrow being a factory, the output should be equal to the requirement. Correct? Marrow being a factory, it should make as much RBC, WBC platelet as the body needs. Now, suppose I get bleeding today. Next 1 week, I get bleeding from a wound or from gums. My hemoglobin goes down. With my hemoglobin going down, my marrow should increase the production of RBC to compensate. Correct? How does the marrow know this? How does the marrow know that hemoglobin is going down? Tissue is not getting oxygen. Tissue hypoxia. How does it know? Because when the kidney has a tissue, when the kidney does not get enough oxygen, the kidney makes and secretes erythropoietin in the blood. This erythropoietin is a protein stimulator. Erythropoietin, so kidney is a sensor. Kidney is a sensor. Erythropoietin will through the blood go to the marrow and say, man, increase your production of RBC. Same thing happens for platelets. Okay. Sorry. Okay. Same thing happens for platelets. In the case of platelets, there is something called as thrombopoietin. When the platelets go down, more thrombopoietin will enter the marrow and stimulate it. So in ITP, because platelets are getting consumed, serum thrombopoietin should increase. What has been seen is it does not increase very well. Why? We still don't. So if you had to plan treatment for ITP, you will say autoimmune, so give immune suppressant, right? And low thrombopoietin, so give artificial thrombopoietin. Very simple. ITP treatment is very simple and logical. In renal failure, you have low erythropoietin, low hemoglobin, you give erythropoietin. Similarly, in ITP, thrombopoietin analogs are available. Before we go to treatment, let us just see which patients are at a high risk of bleeding. So people who have skin bleeding, petechiae, purpura, ecchymosis, they look very scary. Family will be scared. But if they have wet purpura, that means mucosal bleeding inside of lips, buccal mucosa, palate, gingiva, that really means this patient, child or adult, has a high risk of serious hemorrhage. Serious hemorrhage means intracranial, genitourinary, gastrointestinal. Only skin bleeding means no problem. Wet purpura, high risk feature. All right. So patients who have wet purpura or they have hypertension, because hypertension means the heart is pushing blood and it can break the capillary, leading to bleeding. Older age, so patients less than 40 have much less risk of bleeding. More than 40, the risk of bleeding increases manifold. Okay. So age, blood pressure, wet purpura. These are patients who are at a high risk of bleeding like intracranial hemorrhage. Okay. When we diagnose ITP, we call it newly diagnosed. Up to 1 year, we call it persistent. After 1 year, we call it chronic. Why 1 year? Because in some patients, they will have acute ITP. You give short treatment and then it will reverse. In 2/3 of children, acute ITP will never become chronic. Even after you stop immune suppression, platelets will be good. So we give it time to see whether it reverses. In 2/3 of children, it will reverse. In 2/3 of adult, it will not reverse. So majority of the adults, acute ITP will become persistent and chronic. They will require long-term treatment. How aggressively should we treat? If they have wet purpura, if platelets are less than 10,000, 20,000, right? They are at a high risk of bleeding. You have to give aggressive treatment. Platelets more than 30,000, 30, we don't even treat. Chronic ITP patients, platelets more than 30,000 don't bleed because our body does not need 1.5 lakh platelets. Nature has given us more than what we need. Our body does not need 14-gram hemoglobin, right? Up to 30,000 patients hardly bleed unless there is injury. Correct? Unless there is injury. So more than 30,000, we don't treat. Less than 30,000, yes. Less than 10,000, you have to treat quickly. Okay. How do we treat? I told you, this is the platelet cell membrane. This is a thrombopoietin receptor. Thrombopoietin will go and get attached to it and it will stimulate the megakaryocyte to make more platelets. Not only megakaryocyte, thrombopoietin also works on the stem cell in the bone marrow, the stem cell. And it will push the stem cell to make everything, RBC, WBC and platelet. Everything. So thrombopoietin is a very important molecule. And that is why we use it not only for ITP, we also use it for aplastic anemia, bone marrow failure, because it will stimulate the marrow to make all three kinds of cells. And other causes of low platelets also, hepatitis C related ITP, blah, blah, blah. We have to remember when we start treatment, there are some medicines which will increase the platelets quickly. There are four medicines which will increase the platelet quickly: steroids, IVIG, anti-D, and thrombopoietin analogs. IVIG will work in 1 or 2 days. High dose DEXA, high dose steroids will work in 3-4 days. Anti-D also works in 1 or 2 days. So anti-D, IVIG are the fastest. Then steroids. And these thrombopoietin analogs, that is romiplastim and L-thrombopag, they work within 1 to 2 weeks. So we have to quickly increase the platelet count so that the patient is safe, right? And if it helps in 1 week, great. The medicines that we give, excuse me, including steroids or immunosuppressants or L-thrombopag, romiplastim, I mean, these are the thrombopoietin analogs. They have to sustain good platelet count. They have to reduce bleeding, right? And you have to give the right dose. Giving lower dose will not help. This is a proper dose. So steroids, high dose DEXA, we have to give 40 milligram OD for 4 days. Or pediatric, we give 0.8 milligram per kg per day for 4 days. IVIG, you have to give proper 1 gram. L-thrombopag, you have to give proper 50 milligram, 75 milligram at least for most of the patients. Many patients need more. So, if we give medicines properly, patients stay stable. We start off with a diagnosis, do a bone marrow. We, in a low platelets patient, we try to get the bone marrow aspirate report in 2 hours. Do the marrow, tell the lab, stain it. If the pathologist is there, great. If our pathology friend is not there, we go and see the marrow. We ensure the marrow is packed. There are enough cells. Factory has enough workers. There are no abnormal cells, no leukemia. And there are enough megakaryocytes which make platelets. We look at these 3 things. We say, okay, marrow looks healthy, must be immune thrombocytopenia. We start high dose steroids. We give this for 4 days. And then we give prednisolone 1 milligram per kg for 4 weeks and then quickly taper and stop over 2 weeks. To this, we add thrombopoietin analog from day 1. From day 1, we add L-thrombopag or romiplastim. So that within 1 week, the patient is really stable. Platelets are good, no panic, right? No panic. And then as the prednisolone is being tapered, if the platelets again start falling, you know this is going to turn into persistent ITP, right? At that point, we start a second immune suppression. So azathioprine or mycophenolate, because you have to taper and stop platelets, steroids. You have to taper and stop steroids. Otherwise, there'll be side effects. So we add a second immunosuppressant. So azathioprine, mycophenolate, dapsone. And until these start working, because they are slow acting, your other immunosuppressants, azathioprine and all that, take 3 to 4 months to act. Until then, we continue thrombopoietin analog to keep the platelet above 30,000 and safe. Okay, this is how we treat patients. However, in the last 2 years, there are multiple multi-drug regimens which have been published. One of them is what is called as total therapy, where on day 1, you give steroids as usual, you give L-thrombopag as usual, but you also give rituximab, anti-CD20, low dose, 100 milligram, once a week for 4 weeks, total therapy. Now, what happens is, if we use the older technique, steroids, TPO, second, immunosuppressant and all that, by the end of 1 year, 60-70% of patients are going to be still needing treatment. But when you give total therapy, that is in the beginning itself, you give rituximab, good immunosuppression, 80% of patients don't need any further treatment for at least 1 year. So this is also an option today, instead of continuing second line immunosuppression and all that. There's good data coming out. So what do we actually do? I've told you, platelets less than 1 lakh, we start evaluating. More than 30,000 stable, no mucocutaneous bleeding. Yes, we will evaluate, we'll do marrow, but you don't have to start treatment. in chronic ITP. You can watch initially closely, do frequent CBCs, and later on, see them once in a while, but they need long-term follow. Platelets are less than 30,000, but no severe bleeding. No severe bleeding. Okay. Pediatric, start steroids, TPO agonist. Wait and see if they are going to be persistent or not. 60% will not require further treatment. Adult, 60% will need further treatment. If they have money, we give total therapy, because total therapy will cost, almost 1.5 lakhs for the first month, 1.5 lakhs. But it works in 90% of patients. If they can't afford total therapy, no problem. Steroids, immunosuppression, TPO itself can do a lot of good work. Okay. And 60% of adults will need long term. What about those patients whose platelets are less than 30,000 and they have life threatening bleeding? So they come with hematemesis or bad hematuria, right? In those, we need to urgently bring the platelets up within 1 day. Within 1 day. How do we do that? You can give IVIG, anti-D. Usually in 24-48 hours, platelets improve. Now, there are some patients who come with intracranial bleed. There you can't wait for 24 hours. There are no platelets. That patient will continue bleeding and die in 12 hours. Right? So whenever our ITP patients come with headache, vomiting, from casualty, we call neurosurgeon. You will have to do emergency surgery. We are moving the patient to CT scan, do a quick CT plane, ask somebody to run to the blood bank and bring some platelets and give platelets. In ITP, platelets are given only in life-threatening bleeding. Otherwise, it doesn't work, because whatever platelet you give, the immunity will kill it. In 8 minutes, half-life of platelets in ITP is 8 minutes. So we only give when there is severe bleeding. So you ask somebody to go and get platelets, rush to CT scan, CT plane shows bleeding, call neurosurgeon, call anesthetist, keep OT ready. From there, directly neuro OT. Because this bleeding is not going to stop. In a closed cranium, it will lead to raised ICD and the patient will die. There is no time. As the neurosurgeon starts the burr hole, we call the general surgeon parallelly. Say, boss, come and do emergency splenectomy. Because when both are started simultaneously, emergency splenectomy, once the splenic vessels are clamped, blood flow is not happening in the spleen, suddenly platelets go up, because spleen is the site of destruction. So we do an emergency splenectomy. Like this, out of 4 or 5 patients in the last 20 years, we've saved about 2 or 3 patients. Otherwise, they would have died. Right? So this is how we suspect, diagnose, and treat patients who have ITP. That's our team, which actually does all the work while I give lectures. And, we've created multiple departments across the country and other countries as well. And the recording of this lecture will also be on YouTube. Thank you so much. I'll be happy to take questions.
If there is a cerebral bleeding, as you said, and the recovery rate is hardly 50%, you said, I think that's what they got.
See, everything depends on whether they come to the right hospital. Whether, there is somebody who says, no, man, we have to do this. And suspect, quickly do all of this. Literally in 20-30 minutes, the cranium should be opened up. It's like a trauma. When trauma patient comes, you have to have a trauma team to handle it. All right. Thank you so much.